All right, everyone. Good morning, good afternoon, maybe good evening. My name is Olivia Nava, and I am the HCD and co-creation lead for the Momentum Routine Immunization Transformation and Equity Project. It's a USAID project. For the rest of the session, I'll just be calling it the project. It's a long name. And our session is on uncovering the drivers of childhood immunization inequality with caregivers, community members, and health system stakeholders. This is a presentation about our co-creation and assessment process that we use the human-centered design approach. And this is sort of the results from our work in the DRC, Mozambique, and Nigeria that have taken place over the past couple of years. So thank you for joining us. All right. So I am joined on the call with my esteemed colleagues, Dr. Malongo from the DRC, Dr. Sigawuki from Mozambique, and Dr. Yakubu from Nigeria. And these are all of our country leadership in our project, in these three project countries. So this is where we're going today together for the next hour. We're going to do a little bit of a background. I will present a background on our co-creation and assessment phase, which is the purpose of this whole presentation, and our HCD approach. So I use HCD as a short term for human-centered design. And then my colleagues will go over our co-creation and assessment methodology. We'll do a little bit of a skills building. So we'll ask for some active participation from you all on a method that we use, that we develop specifically to bring more of an equity lens to some of the work we're doing specifically with female caregivers. And then we'll have a panel discussion talking about sort of the successes, the value of using this type of approach. And then we'll open it up to Q&A. So you can ask questions in the chat and we can answer them. So that's our journey today. So we'll start with the background. So our project applies best practices and explores innovations in equitable, how to deliver equitable coverage, immunization coverage in USAID supported countries. It's a 5-year project that began in 2020 and is currently operating in 18 countries throughout the global South. And our work is to build countries' capacity to identify and overcome barriers that are sort of these entrenched obstacles to immunization, and in reaching specifically zero dose, children that have never received a vaccination, and under-immunized children or low dose children. So you might hear us use both those terms to refer to children who have incomplete vaccination. And then also older populations in reaching life-saving vaccines. This also includes, integrating it into healthcare, and then also we have done a lot to rebuild the health systems and immunization systems after COVID, in addition to also being a part of COVID-19 vaccination rollout. So those are sort of what our project overall is. And the challenge just for the project in general has been to reach, in 2021, there were 18 million unvaccinated children in the world, and so we are not reaching them, and we want to understand why we're not. And the reason that this is a challenge is because we felt that we aren't really understanding from their perspective the challenges that they're facing in reaching vaccinations. So our approach really is about identifying what are those barriers or those enablers or facilitators of vaccination that these caregivers are facing of the low dose or the zero dose children. And then what we would do in our approach is around to use an assessment that identifies those barriers and facilitators, and then to co-create solutions with them, the caregivers and other local stakeholders and community members and community leaders to design locally appropriate interventions. So that's our approach. Our theory of change are really just those, like I said, strategies rooted in co-creating solutions with these beneficiaries and key local stakeholders of the interventions. So I wanted to just take a second to really dissect or, kind of break down this term co-creation. We do hear it a lot in global health and in other sectors, but we wanted to make sure that we were very clear about how we use it. And so co-creation throughout our presentation is going to mean the co-creation and assessment period. So that's at a period where we're coming in right at the beginning of a new country project, and we're trying to figure out, what are going to be the priorities for our work plan and for working in the country. So that part is one way that we say co-creation. And then the other part is really just this key mindset around co-creation as how we want to work with stakeholders. And so that mindset early on in the project, I can show you in a second the principles that we built upon, we built with that. So going back to the first term around the co-creation assessment phase, the human-centered design approach we took during that time is about understanding sort of these root causes of why people aren't getting vaccinated or not continuing their vaccination. And so we did this directly with stakeholders, both community and health system stakeholders, through in-depth interviews, through focus groups, which are a little bit more, kind of the traditional qualitative methods. But then what we did is we quickly synthesized and took insights from that data collection process. And in that same period, we then went and did these co-creation workshops in the locations where our stakeholders are, live and work. So they weren't like in this, the capitals and the city centers, but actually going out to the districts and wards that communities that are most facing these issues. And so we co-created these solutions to the problems that had emerged through that data collection. And so when we talked about who we were co-creating with, it was bringing back those at the workshops, it was bringing back caregivers, it was bringing back community leaders, it was bringing in the community health workers, as well as the health facility workers, and also sort of that district or health zone level folks as well. So, but that was not limited. We had a lot of different configurations based on what the problems were for that specific area. So when we talk about as the mindset of what co-creation is, very early on, we in the project, we brought a lot of our partners together. We're a 7-partner organization or project, and so we really wanted to think about, well, what do we mean when we say co-creation? Because people throw this word around a lot. And the first thing that we really wanted to be clear is that co-creation is more than a workshop. So co-creation is really about the continued, engagement with the people that we bring to the workshop past that workshop time. So when we think about how we're designing our work plans, we also integrate continuing to go back to some of those communities and working with them on realizing these solution paths that they had identified. So in that sense, we're trying to share power with different stakeholders across the system and elevate the voices that often aren't heard in the health system. So working with those health facilitators, vaccinators, create shared goals. Build on what's already been done is a very big one, so we're not trying to come in and do something totally, radically different, but we really, when we come in for our data collection specifically, we do a very big deep dive and scoping on what is the existing information that's already out there, what studies have already been done that we don't have to replicate. And then the other two are a little bit more tactical, listening and adapting, using existing meetings, so we're not creating new meetings, and then reflect and iterate on some of the challenges. So we kind of are a little bit more iterative in our delivery of our co-creation. So these are some of the key other mindsets that we're using, kind of covered co-creation, but this idea of learning by doing, so staying open-minded when we're working with communities about as new information arises, we want to make sure that we're really creating a learning environment in the work that we're doing, and keeping a discovery mindset. So staying curious for the people. So when we go back, it's not like, oh yeah, we got what you said, but actually staying curious, like, well, hey, how is that going? Can we get feedback? What are sort of those feedback loops? Observing context. So even though we did all of these kind of interviews and as part of that co-creation data collection process, we are off, like to be observant of what people are saying, understand the context, and making sure that we are really seeing what people are doing versus, specific only what they're saying. Building empathy. So this is a tool later that we're going to show you that builds, kind of how we build empathy for the female caregivers. But that is a key mindset in human-centered design, just full stop, like, is really wanting to understand what is that lived experience and staying curious. Like, I don't know your life. So how is, how we're curious, why health services aren't coming to your area, or where would you be better served if this, if it seems that the times for vaccination aren't working for you. So what would that look like? And always be prototyping as a mindset. So, we're always learning. So that's, again, sort of another way of saying we're always learning, always getting new information. Maybe we'll try a different day for a vaccination, or a different set of hours for vaccination services, and see how that works based on, people telling us that's what they're interested in doing. So it's a lot of just the iteration on getting things better. So I'm going to start with a poll, and I think the organizers have a poll for us. So the question for you, so that's sort of the, let me just check this chat. So the question for you is, how would you categorize your use and interest in human-centered design? Is there a poll for the folks? I'm not seeing the poll, so let's see. Conference folks, technical folks, are you there? All right. Well, we will move forward. How about folks just put into the chat then? So these are, it looks like, okay, we're having a little bit of a technical difficulty, but how do we can iterate. So how about we just put into the chat if you have an answer. So answer one in the chat if you use HCD regularly in your work. Answer number 2 in the chat, I have some knowledge of human-centered design, but don't regularly use it. Number 3, I don't understand human-centered design and want to learn more. And then 4, I have no interest in human-centered design. So just, we can be honest. So let's see what we have here. All right, we got some 3s, some 1s, some 2s, 2s, 3s. All right. Okay, great. There's a lot of folks who kind of fit into that 2 and 3 category. So it's great to have you here. So thank you on it. And someone who's an expert. I mean, we all can be experts in a lot of ways. So great. Yeah. So great to see it. So we'll move on. I'm going to pass it over to my colleagues who are going to walk us through what our approach is. So 1 second. All right. So Dr. Betuel, I will pass it over to you, I think, first. Oops.
Hello. So I'm going to present regarding to the objective. So the overall objective of this work was to inform our project activities to have as a large an impact as possible on immunization inequality. To do that, we design an assessment and the co-creation process to identify the persistent barrier to vaccination as experienced by caregiver or zero dose and their under-immunized children, and to develop local relevant solutions. So next slide. So we conduct in-depth interviews and the focus group discussions in community with a high number of zero-dose and under-immunized children. To do so, we interview caregivers, community members, health workers, and health system manager to understand the persistent barrier and the root of cause they faced. We use the UNICEF Journey to Immunization framework, which is the diagram that is on the right side of this slide, to guide our data collection and thematic qualitative analysis. We conducted the interviews and real-time analysis rapidly, typically in the span of the few days for a given community.
All right, we can pass it over to Dr. Salva.
Bonjour à tous. Alors, bien que notre collecte de données était focalisée sur la méthode qualitative, nous avons également pu collecter des données de vaccination, des données quantitatives auprès des infirmiers qui avaient en charge la vaccination, la gestion des stocks et aussi différentes données mesurables. Et immédiatement après, nous avons organisé des ateliers de co-création dans ces différentes communautés. Et ces ateliers, non seulement ont été organisés au niveau communautaire, mais également au niveau des districts, au niveau des provinces et même certains au niveau des provinces. Et dans ces différents ateliers, nous avons invité les personnels soignants, les membres de la communauté, ainsi que les autres différentes parties prenantes qui interviennent dans le système de santé pour discuter de différents paniers et aussi de pouvoir identifier et créer des solutions adaptées à leurs besoins. Diapositive, s'il vous plaît. Alors, nous avons également développé un outil qu'on a appelé l'écosystème de la mer. Et cet outil nous a beaucoup aidé pour pouvoir créer l'empathie auprès des personnels soignants et ainsi identifier comment chacune des parties prenantes pouvait aider à rendre beaucoup plus accessibles les services de vaccination. Et bien sûr, nous serons vraiment heureux de pouvoir vous présenter cet outil à la fin de cette présentation et voir si cet outil a pu être utilisé au atelier. Et également, cet outil bien que cet outil nous a permis de créer cette empathie auprès des personnels soignants, mais il a également permis de démontrer le rôle que chacun des parties prenantes pouvait jouer dans la vaccination des enfants, que ce soit au niveau de ceux qui interviennent dans le système de santé, les communautaires, les leaders au niveau de la communauté et même les membres de famille. Et on a aussi utilisé d'autres outils de HCD pour réfléchir ensemble sur les solutions que notre projet a pu implémenter au cours de la mise en œuvre. Merci. Je vais passer la parole à Dr. Yacoub.
Yes, thank you. And in the 3 countries referenced here, DRC, Mozambique, and Nigeria, we found that the caregivers of zero-dose and under-immunized children experienced the intersection of multiple barriers to immunization. And these are related to gender, poverty, access, as well as service experience. And with each additional barrier, the qualitative risks of being zero-dose increased. We also found that the immunization programs were not meeting the very needs of the vulnerable. While pro-equity strategies such as outreach vaccinations, microplans existed on paper, and they were suboptimally implemented. And in terms of identifying inequalities, we found that the qualitative approach provided new insight, further insight into the drivers of inequality. Next slide. On the point of this particular identifying inequality, we also found out that the co-creation workshops were very effective in building empathy for caregivers and an understanding the rudiments or the different types of inequality as they exist. While the co-creation workshops were successful in identifying local solutions, we recommend strongly that this approach should be used whenever possible to inform local planning. Merci. Thank you.
Merci, obrigada. Thank you. Yeah, so we're going to transition. I see if there's any questions in the chat before we transition. Okay, didn't think so. But to sort of this method in action. So where this method, oh, I put my video back on. Where this method sort of derived from is during that, when we were first embarking on this whole co-creation and assessment phase, we had a lot of feedback when we were doing our pilot, which was about a month long in the DRC. And one thing that kept coming back was some of the data collectors were saying, oh, we're okay with saying, well, the reason why, there's a lack of, where the vaccination is a problem is because, mothers are lazy, mothers are, they are negligent. So we were thinking, well, that's probably more to it behind it. So we created this tool that shows that, when we were actually in our focus groups or in our, when we were reading back all kind of what they're saying in the focus groups and in the in-depth interviews, we were seeing that actually mothers were saying they did want to get their children, many mothers were saying that they did want to get their children vaccinated, but that, there are a lot of issues around when the time, whatever the issues were, or the barriers for them seeking those services, whether it was because they had to work or they didn't have transportation or the roads were bad to the health facility or they couldn't get to the health facility early enough. So, for when vaccination services were happening. So we created this tool called the vaccination ecosystem tool, the mother's journey, because oftentimes, even though there are many caregivers that are a part of the solution, oftentimes it was on the female caregivers who are responsible for making sure that their children were getting vaccinated. So I just wanted to take a moment to sort of show this tool in action. So I'm going to ask folks in the chat, and this is sort of how it went during our co-creation workshops. We would, in some settings, in some countries, they did this as like a full group exercise, and the co-creation workshops were pretty small. We kept them sort of small to be nimble, and so people felt a little bit more intimate and that more people would speak. So they were less than 15, generally around 15 to 20 folks that were there, 25 folks. And there would be a mix of health system folks and community members, and that included caregivers. And so we kept the caregivers together in a group with some community members, and then we kept the health system group together. And so sometimes this was done in those smaller groups to make it more so people could speak with a little bit more agency and a little bit more freedom. So what we're going to do is just sort of model this right now. So if you can use your chat, the question would be, in what ways, and this is very much like a social behavior change type of framing for this work. And so this is a bit of an HCD tool that leans a lot on social behavior change approach. So when we think about the mother and her infant, they would face a lot of people in her circles who would be helpful or enablers, for her to get her child vaccinated. And then there are also these same types of people who could be barriers or obstacles to getting the children vaccinated. So can you give me, folks on the Zoom, an example of how maybe her mother-in-law might be an obstacle to her, to the mother taking her child for vaccination? In what way could a mother-in-law be an obstacle? Yeah, that's true. So we would say, yeah, so I can actually do it in real time. Oops, sorry. Yep, those are all obstacles. So what folks are saying in the chat are family traditions, overloads daughter-in-law with chores, delays decision, reliance on rumors and misinformation. Yep, there's religious issues that might be part of that. Telling your children they don't need to get vaccinated. Yeah, there's a lot of great negative information about immunization. Yep, these are all great. Does not understand the value of vaccinations. Yep, these are all barriers. So in what way, now let's flip that. In what way could a mother-in-law enable a mother and her child in getting that child vaccinated? Like, what are the ways that they are really supportive of that? What could they do? What are things they could say or do? All right, let's see what we got here. Yeah, so what's the way that they can be an enabler or facilitator, we say? Yep, help with the housework, offer to go with her. These are right. Ropes in support from father to facilitate access to the health center. Yep, these are all great. Educate the daughter-in-law on the benefits. This is right. Right. Addressing false religion, reminds her of vaccination dates. Yep. Understands the importance that she can tell her, reiterate some positive language around the values, encourage her on her decision. Yes, these are all correct. So then, thank you for those. Tell them of the advantages, of course. So thank you for your participation. I appreciate it. So now we can look at it on the health center side, or the health system side. So we can, what we do often during this, and I'll show you some other examples after this, but I'll do that after. So let's go to the health system side. So in what ways could, say, a health facility manager, so somebody who's, who's in charge at the health facility, what ways might they be an obstacle or a barrier to mothers, seeking vaccination? Yeah, so we're looking at the health system side. Unclear clinic flow. Exactly, totally. Yep, that's very true. What are other ways that health facility managers might be barriers? Lack of human resource. Yeah. Vaccine outages. These are all very real. Long wait times. Of course, the care is not respectful. Yep. That's a big one. Service hours that make it difficult for families. They will need, getting to the facilities requires financing. Rude health workers. Yes. Very true. Heard a lot of some of that. Assuming mothers don't want the vaccination. Yeah. Not even asking them. It's a missed opportunity. The attitude. No vaccination calendar available, misconceptions, lack of dedicated care, or too much workload. Yeah, there's empathy even for the healthcare workers, right? They have too much on their plates. Untrained health workers, and distance to facility. Yep, lack of EPI systems in the health center. Poor quality of care. Not a priority. This is true. These are all that's kind of the basis of it, right? All right, well then what are the ways that, let's flip that. Let's end this tool on a positive note. So what are the ways that a health facility manager might be a facilitator of vaccination services? So how might they facilitate and enable mothers and other caregivers to get the children vaccinated? Supporting community outreach. Yep, both of them, to get those two at once. Yeah, a clinic flow that reduces waiting times. This is a big one. Yep. Plan and inform mothers about the time. Use dialogue days, door-to-door campaigns, awareness and education. Great. Culturally appropriate vaccination flyers in their languages that the mothers understand. One-stop shop for babies and mothers. That sounds great. Regular outreach. These are all great. Yeah, so thank you for your participation in this. This is all really great answers, and we can show you that at the end of the day, when people did this activity, yeah, please keep reading the chat, but I'm gonna make sure. So this was just sort of, I just wanted to show you different ways, the very tactical piece of, how this was formulated. So in the DRC, the teams there did it like how I just did it, but they were typing actively, like on a projector. And then in Mozambique and in Nigeria, we did it on paper. So this is an example of what we did at first was we spent time asking everybody, well, who are the people and actors? We said the term actors, but who are the actors in the mother's and in a mother or caregiver's life? So for the first round was sort of the family and the community members that are just the different people that are present and offer support, or could be potential obstacles. So just who are the people in her life at the community level and at the family level? And then we were like, well, who are the people that she might interact with at the health system level? So that's the one in Portuguese. And then this is the one that we did for in Nigeria. So, you have all these different folks, and then we would ask the people in the session, well, who do we want to, let's choose a few of these to really understand, what ways that they could be enablers or facilitators or obstacles. So that was just so I could show you if you wanted to do this exercise for yourself, that's how we executed it. And sort of the value of it is that at the end of the day, folks were meant to see how everybody has a role to play in getting children vaccinated. And so it was really pointing out that you yourself, whoever was in that co-creation workshop room, is like, oh, you're the neighbor. Here's ways that that you could play a role in that. Oh, you're the the district leader. Well, here's ways that you can do that. And so that everybody took the onus of seeing that the mother actually is facing a lot of barriers, and here's all the barriers that she faces, and she has sort of the most kind of responsibility on that child, but also the least in terms of making maybe some financial decisions in her life. Being able to take time away from work may not be possible. So it's really just showing that there's ways that we need to have empathy for these caregivers and not just assume what their life is like. And so showing that every one of us has a role to play. So that was sort of the point of what this whole exercise does. And you can see the sort of ripple effects of it. And when people are then not able to sort of blame mothers when we get to the solution part of our co-creation workshop, but really start to think more broadly around what solutions could look like. All right. Yeah, so then this is just sort of I'm not going to read all of this, but just showing you the different, if you want to see, there's other caregivers, and these are just sort of a summary of the different types of groups that we, different types of actors that we highlighted, from caregivers all the way up to like district, immunization, health system folks. So yeah, just wanted to show you that. And we're going to transition now so that we have enough time for any questions to our panel. So I'm going to invite, yes, slides. Yeah, these slides can be shared, sorry. For sure. Okay, so, oops, let's see, we got some questions already. Okay, we can answer this question first. Okay, so from our discussion, co-creation is a systems-focused tool, which is great in that sense. It does not focus on blaming any one part of the ecosystem, but rather on how these can better come together to deliver the desired outcome. Oh, okay, because yeah, This clearly goes beyond immunization. I would imagine that the investment in co-creation could be efficiently applied to simultaneously look at multiple endpoints that might align well with zero dose, like care seeking for a sick child. Yes, exactly. It can be done with a lot. Yeah, exactly. So it can be used for beyond immunization. I think it really, at the end of the day, is a tool for, is an empathy tool, and also a tool, because knowing that a caregiver has many responsibilities beyond immunization in her work. So, I mean, in her life. So, you know, for her children and what is expected of her in her child's health, or children's health. And so that, in that sense, it doesn't have to be specifically immunization. It can be a tool that is used for other care-seeking issues. Yeah. So thanks for the question. So we do have a panel, and continue to ask questions along the way. And after, you know, we have about it's about 7 minutes of panel, 7 to 10 minutes of panel discussion, and then we do want to open it up for broader questions. So I'm going to bring my colleagues back into the conversation. And I think that's our last slide. Yeah. So the question that I want to start us off with, and we'll do a little bit of popcorn style, but how has your thinking about co-creation evolved through this process? So when we think about, you know, from the principles to diving deeper on what we don't know in terms of, you know, root causes, engaging caregivers and empathy. So, you know, how has your thinking about co-creation evolved by implementing this process? So I'm going to open it up to Dr. Salva first to answer that, and then it'll be, we'll go to Dr. Yakubu and then Dr. Sigawaki, sorry. Okay, so Dr. Salva, I'll pass it over to you.
Merci beaucoup. Merci beaucoup, Olivia. Alors, vous m'entendez? Ok. Voilà, je disais que pour nous, la co-création nous a permis de mieux identifier et mieux comprendre les différents défis et boulots d'étranglement auxquels le programme avec lequel nous travaillons, le programme de vaccination, a pu faire face. Et cette co-création nous a permis surtout ensemble avec les différentes parties prenantes, d'identifier tout ce qu'il y a comme possibles solutions adaptées à leurs besoins. Et également, ça a permis cet engagement à différents niveaux de différentes personnes, a permis une identification de solutions à appliquer face aux problèmes. Non seulement on a identifié ensemble les problèmes, mais ils se sont engagés dans cette implémentation, mais aussi dans le monitorage des différentes activités qui avaient été identifiées comme solutions. Merci, j'espère que vous avez pu m'entendre.
Yes, for me, over 10 years of designing programs, I've used data and document review. But with the co-creation approach, we've had the one-on-one interaction with the community members. We talked to them and they opened up. And amazingly, what came out very strong from this interaction is that the beneficiaries, the community members, they had deeper insight into their problems. And they also provide very concrete solutions. And what we did, since we're planning to develop our work plans for submission to our donor, we refined those solutions, those problems, and we created activities from them. And once we got secure approval from USAID, we started implementing with the community members together. And what the message here is that once you involve the community level persons or people in the early stage of your design, you will find out that you'll get an enhanced result within a very limited duration or period. And this is what I will recommend for program managers moving forward. Thank you.
Thank you very much. From my side, to answer this question, co-creation is an approach involving more people, mainly those who live or experience and feel the problem. So using co-creation, we understood how people felt and see themselves as part of the process and identify appropriate actions to solve the problem. Co-creation is a great approach because the people felt part of the problem. For use, once we learn at the beginning of the project the way that we use co-creation for planning, we went to a specific problem and we target activity, and the planning was simple, especially because we identify the realistic activity to address the persistent problem. And we did not, from the beginning, we use not only for immunization, we use also, not only for routine immunization, we use also for the COVID vaccination. Thank you.
Thank you all. So yeah, let's continue on that thread. So what the question I have for now is like, how are you continuing co-creation in your work? So, you know, as we said in our first co-creation principle, co-creation is more than just a workshop. So can you all give us examples? And I think I'll start with you, Dr. Betwell, because, you know, and how, you know, you have been continuing to use that in your work in Mozambique since the co-creation and assessment phase. So we'll start with Dr. Betwell, and then we'll go in reverse order. So then we'll go to Dr. Yakubu, and we'll end the question with Dr. Mulongo. So why don't you continue, Betwell?
Thank you, Olivia. Yeah, COVID vaccination is one of example of use of co-creation planning process. So COVID vaccine bottlenecks, working with health facility workers, district health managers, that was one of the examples to use co-creation for planning. We use this same approach to understand the persistent barrier to COVID vaccination that were perceived by the health worker, where we use co-creation to understand the solution in development of integrate the plan of COVID vaccination into primary health care. Over.
Yes, for Nigeria, we commenced the co-creation activity in October last year, and we got approval to proceed in December, and we started our work in January. However, 4 months down the line, we went back to the same community to understand if there are changes and to what problems exist further. And to our amazement, we found that there are some peculiar changes that happened. One is that the local leadership within one of the communities have taken the responsibility of line listing new birth and also tracking defaulters. So we believe we are currently processing, analyzing the findings, and which we are going to share widely once we complete. But the key message here again is that engaging the community levels or the beneficiaries from the design of the project to implementation. It reduces one, government identification or government bureaucracy in addressing the identified challenges at the local level. And it brings about ownership of the programs, as well as facilitating or enhancing the result expected of the project. Thank you.
Alors, pour la FDC, nous avons continué à utiliser le processus de co-création dans la gestion de données de vaccination COVID. Et ensemble, avec les différentes parties prenantes, nous avons pu, après avoir identifié tout ce qu'il y avait comme défi, proposer des solutions afin d'améliorer la complétude et la quantité des données de vaccination COVID. Et entre autres solutions qui avaient été trouvées, identifiées, que nous avons pu mettre ensemble avec le programme de vaccination ici au RDC, ça a été la mise en place d'un système de DHS2 agrégé. Nous avons ensemble procédé à la révision des différents outils de collecte de données et les adapter à la réalité de COVID. Mais aussi, après tout cela, nous avons procédé à la rétrosaisie des différentes données qui étaient logées dans les bases externes et qu'on a pu transférer dans le DHS2. Et tout ça, c'est ensemble avec le programme de vaccination, les autres partenaires qui interviennent dans la vaccination et bien sûr notre projet MRIPS. Merci.
Well, thank you all for that question. So I just wanted to encourage if there's questions in the chat. I have one more question that I will ask, and then I can start to collect and see other questions that come up. So for the last question, what were your biggest surprises or aha moments during that co-creation and assessment phase? So we'll start with Dr. Yakubu, and then we'll go to Dr. Salva, and then we'll end with Dr. Betuel. Thank you.
Yeah, it's simply put, it's amazing how the beneficiaries were able to articulate problems associated with the primary outcomes of vaccination and what they believe are the solutions. And these solutions, if implemented, brings about the needed result. So how they were able to articulate the issues relating to the low vaccination coverage was simply amazing. And I believe it has changed the mindset of how we program managers think of providing solutions based on reviews, based on data that are available. Over. Dr. Betuel?
Yes, thanks so much. I agree with Dr. Yakubu. When we plan using co-creation, we felt like we need really to change the process that we use to plan in Mozambique. And usually we plan before momentum, we plan with district manager only. But when we use co-creation and we plan with the workforce, it's different because they plan what they want to solve. So it's planning with the district or provincial level people only. Already they identify the same activity just to deliver the health service, but co-creating with those who live the problem, because they can tell the problem and implement jointly the solution because they are part of it. They understand the problem very granularly. So I think this is really a biggest surprise, really to involve communities, members, caregiver participating in the planning health delivery services. Thank you.
Alors, pour la RDC, notre plus grande surprise a été ce niveau de responsabilité, d'investissement et d'intérêt à différents niveaux que nous avons pu constater dans cette approche de co-création, dans ce besoin d'identifier des solutions qui soient adaptées afin d'appuyer le programme, d'appuyer la vaccination dans le plan de vaccination dans sa mission. Merci. Hello.
Yes, thank you. All right, so we're gonna, thank you, Dr. Sauki, Dr. Molongo, and Dr. Yakubu for your responses. I think we have a couple more questions before we have about 7 more minutes. So one is really understanding, like what is the scope and scale of the co-creation? So because, these are the USAID funded projects, we had in these 3 countries, we did have different, we did have a lot of resources that we were able to kind of devote to the assessment phase of this work, which in other more traditional kind of like baseline assessments, there's oftentimes, I think there's a question about how does this different, where it tends to be sort of a top-down planning approach where we engage with national and provincial or state stakeholders and make a plan. So this is actually really flipping that. It's like we still do engage those stakeholders at the national level, the national immunization level, as well as and then identify where some of the priority provinces and districts that is really using coverage data to kind of determine that part of it. And there's a significant sort of scoping part of the co-creation and assessment phase where we're looking at existing data and things like that. So the difference is though, we immediately go to the communities. And so each country is really based on like the resources available, so the time available. And so we've really we kind of have had different sizes of the project in each of the countries. So, Dr. Molongo in the DRC, it was, like a 2.5 month process. We went to 8 different health zones over 4 different provinces. But because it was the first one, it took a little bit longer for us to, sort of prototype it. Whereas when we got to Mozambique, that was a 7-week process. And that's just the data collection part. When I'm talking about that, there's obviously like a planning and onboarding the data collectors as part of that process. But in Mozambique, it was truncated down to 2 different provinces, working in 6 districts. And then within each of those districts, there was 2, we had, I want to call it a ward, but it's not a ward in Mozambique. But so, and that was going to, I think, 6 different health districts. And so then in Nigeria, it was even shorter. We had about 2 weeks. I would imagine that at least 3 weeks is probably ideal. And we went to 2 different provinces, and then within those provinces, we went to 2 different health wards. So those were sort of the different scale of the approach. And then but the co-creation workshops themselves were all very similar in terms of the number of people that came. So the people that were interviewed as part of those, as part of the the interviews, the focus groups were invited to come to those workshops. And so that's how we got kind of that mix of health system folks and community health workers. Yes, and let's see if there's other questions. Yeah, we have about 4 minutes to go. How about I'll open up this question to the panelists, but what was the acceptance level amongst healthcare workers? I don't know if if one of you could answer that. I don't know. Yeah, the acceptance level amongst health workers, maybe with some of the work you're doing in with COVID, with Dr. Sigauki or Dr. Molongo, since you've been doing it longer.
Yeah, I can take this question. I think the acceptance from the healthcare workers was high in Mozambique. As I mentioned, usually because of the time constraints, the planning process not involved the facility health worker, just involve the district or provincial health managers to complete the entire planning, not only for immunization, but the whole health system. So using co-creation, we felt that people really welcome this process because they can contribute for those that they need in terms of delivering services. So I can say that apparently co-creation have been adopted, because this year we started in 2021 for the co-creation with MRight. And up to now, the program have adopted in terms of using co-creation and human-centered design for planning in 2023 exercise. All provinces and the district are involving the facility health workers. So I can say that this is part of momentum or MRight legacy in terms of transforming the planning process from top down to bottom up. Thank you.
All right, Dr. Salva, did you have anything to add? It's okay if you don't.
En fait, je m'aligne à ce que le Dr. Bectuel a dit. L'implication des prestataires de soins était vraiment impressionnante, comme je l'ai dit, dans les surprises que nous avons eues à identifier sur le terrain. Et ce que j'aimerais ajouter, c'est que nous avons adopté ce principe de co-création dans toutes nos interventions. Et même là, au niveau de la RDC, nous sommes en plein processus d'intégration de la vaccination COVID dans les soins de santé primaires. Nous continuons à utiliser ce processus de co-création. Donc, ça fait un peu une sorte de marque déposée de nos différentes interventions ici. Merci.
All right, everyone. We do have only 1 minute left, so I think I'm just going to I have to cut the I didn't get to all the questions in the chat, but thank you for your participation. It's been a pleasure to be here with you in community. And I will send the slide deck in a PDF form to the organizers, and hopefully there is a way that you can receive it. All right, with that, thank you to all of my colleagues on the call, and I hope you all have a great rest of your day.
Thank you. Bye.
Thank you.